Okay.
Hello, sir.
Hello.
Sir, am I audible, sir?
Yes, sir.
Yeah.
Wait, my slides are not moving.
शैलेश भाई
यस यस
यूट्यूब लिंक भेज दिया।
ओके ओके वो स्टार्ट किया गया रिकॉर्डिंग वैशाख सर आर यू देयर
Yeah, sir. Yes, sir.
कैन वी स्टार्ट
Yeah, we can chat.
Hello. Yes, sir.
Hello.
So, can we start, sir?
या today's session is on approach to LMN syndrome and myopathy. So first myopathy will start, followed by Dr. Satish will present. So Dr. Baishak, you can introduce yourself, followed by Dr. Akash, then Dr. Satish will join. Okay, we can start.
Yeah, I'm Dr. Baishak Renaji. I'm a consultant neurologist working in Kochi. So, Arash, we can start. You're
Uh,
from Jaslab?
no, sir. I'm from Fortis Hospital, Mulund in Mumbai only. I'm going to
Okay.
present approach to myopathy. I'm Dr. Akash. Uh, the slides are not moving again. So myopathy is a functional or structural impairment of the skeletal muscles, as we all know. Muscular dystrophies are a genetic myopathy due to disturbances of structural protein or enzymes, resulting in necrosis of muscle fibers and replacement by adipose and
We,
connective tissues.
rather than theory things, we will go more practical because
Okay,
this
sir.
is more practical. Yeah.
Yes, sir. No problem. So broadly, they're classified into hereditary and acquired. So once individual has the symptoms of myopathy, we should ask them the six questions, which are which symptoms and signs does the patient have? What is the distribution of weakness? Is there a family history or not? What are the associated neurological as well as non-neurological signs and symptoms? Uh, what is the temporal evolution, and are there any precipitating factors that trigger the episodes of weakness or myotonia? So the common symptoms of myopathies are negative symptoms like weakness, fatigue, exercise, and tolerance, muscle atrophy. And positives are myalgia, that is muscle pains, cramps, contractures, myotonia, or myoglobin urea. Weakness is the most common and most reliable symptom in myopathy. Weakness can also arise from, that is a neuromuscular junction, which has fatigability, oculobulbar involvement, which is seen commonly in that, the root plexus involvement of the peripheral nerves, which has sensory complaints as well, and the anterior tonsils, where we have wasting more than the weakness. It is asymmetrical. Reflexes changes are early, and fasciculations are very prominent in this. So, uh, with the muscle weakness in myopathic pattern, usually it is a proximal muscle weakness. The individual will present usually with difficulty arising from chair, climbing stairs, waddling gait, or difficulty or to lift the objects which are overhead. Some
See, yeah. When you are practically going to approach a myopathy, so first thing you should know is whether it is element or human,
yes, sir.
because we are dealing about element syndrome. So what all
Element
things
syndrome.
favors it? What all things favors it is element.
So, element will be first. It is like this.
What is the difference in element and human syndromes? Hello, hello. Am I audible?
Yeah, audible. Maybe from mistake.
Yeah, I think Akash said. Mm.
Yeah, Dr. Ajay Kumar, you can unmute yourself and you can answer.
Hello, I'm sorry. There is a electricity problem over here. Fluctuations of the light is going.
Okay.
Okay, sir.
So how will you
Okay.
differentiate element versus human? That is first step.
Yes, sir. So for the element versus human element, uh, will have more uh, uh,
Uh,
flaccidity,
Yeah, spasticity is
reflexia.
a feature of
It will be more
yeah, spasticity, hyperreflexia are
human.
features of human,
Spasticity will
while it
be
is wasting,
human.
fasciculation, hypotonia, all these are features of element.
Hypotonia element.
So
Yes, sir.
element can be either a sensory, motor, or sensory motor syndrome.
Yes, sir.
Can be symmetrical, asymmetrical, whatever it can, but it is either sensory, motor, or sensory motor. So when it's sensory or sensory motor, you think of nerve and all. When it is pure motor, what all things you will consider?
Pure motor will be muscle anterior console.
Anything else?
Uh, root plexus. Even NMGs can be pure
Yeah, anything else?
motor.
Anything else?
Uh,
So it's very
uh,
simple. You start either from distal or from proximal. Distal, it will be muscle, neuromuscular junction, motor nerve, or pure motor root, or anterior console. Pure
anterior
motor root is
console.
very unlikely. So you can make it as muscle, pure motor muscle, neuromuscular junction, pure motor neuropathy, or anterior consoles. Then
Yes, sir.
how to differentiate between these? How to differentiate anterior consoles from muscle?
So anterior console is very asymmetrical. It has
Okay.
UMN signs as well. The
Suppose anterior
reflexes.
console is element type of anterior console. How to differentiate?
Yes, it will have more wasting
Yeah.
fasciculations. It's
Whenever
asymmetrical.
wasting is out of proportion to weakness, there is too much wasting, not significant weakness. That is
Mm.
one feature of anterior console. Then there is fasciculations and fibrillations, all those things. If
Fibrillations.
that differentiate, and there are some patterns also, like upper limb brachioradials is less affected, lower limb you may get more of involvement of your hamstrings like that, but that may be confusing sometimes. But the thing you can remember is if there is significant wasting out of proportion to weakness and fasciculation, there are classical hard points tells you that there is anterior console is involved. Whether it can be degenerative, it can be compressive, it can be part of some uh, something else, but we don't know. But it is just telling you that it is anterior consoles. Then what about NMJ?
NMJ will have more fatigability.
Yeah, correct. And ptosis bulbar involvement with fatigability favors more of NMJ, but there are some muscle disease which can have ptosis and all, but fatigability. So what is difference in fatigue and fatigability? Hello? Hello? Akash, am I audible? Hello? Hello? I think Akash's phone has some issue. No, fatigue and fatigability, these are usually used interchangeably, but they both are not same. Fatigue is a very non-specific symptom which has no objective evidence. Suppose I have viral fever, I am fatigue, I have fatigue. I have cardiac failure, I have fatigue. I have metabolic myopathy, I have fatigue. But fatigability is something which is demonstrable. Upon action, there is a definite weakness. After looking upward for some time, there is ptosis. After doing an activity for some time, he has weakness. After chewing for some time, he has weakness. That is fatigability. That is an objective evidence is there. Fatigue is very non-specific thing. Postmenopausal, old age, vitamin deficiency, nutrition deficiency, fever, post-viral, organ failure. So everything will have fatigue. Okay. Agash, are you there? Okay. And now we will discuss when we discuss about the peripheral nerve. So that was the first step of both approach to pure motor syndrome. So it can be either muscle, neuromuscular junction, or a motor nerve, or an antiphon cell. You divide from all those things what favors what. And muscle, what are the type? Like one is by the patterned approach to the muscle. That its slide was there. He
Yes,
was
sir.
showing. Yeah.
Yeah,
Other
yes, sir.
than the
We can.
patterned approach, before pattern approach, a muscle weakness, how you want to approach. It can be either an episodic weakness or a persistent weakness. It can be either an episodic weakness or a persistent weakness.
Yes, sir.
The episodic weakness can be associated with an exercise, not related to exercise.
Yes, sir.
When it is related to exercise, associated with myoglobinuria, you think of metabolic myopathy or couch potato syndromes and all. And if it is unassociated with exercise, you will think of periodic paralysis syndromes.
Yes, sir.
Okay. Then you have something which has a persistent weakness. The weakness is persistent.
Yes,
That
sir.
can be divided into acute, subacute, or a chronic over years. The chronic, usually chronic are genetic,
Genetic disease.
while acute is
Acute can be
acute. Yeah, acute and subacute are
inflammatory,
usually acute and subacute is
inflammatory, toxic, infectious, or endocrine
acute. Yeah,
myopathy.
all these acute myopathies. The
Mhm.
same thing. This diagram only.
Yes, sir.
So chronic can be progressive and non-progressive. Non-progressive is
Mhm.
congenital myopathies. Correct. Okay. So
Yes,
that
sir.
is the second step towards assessment of weakness. First, I
Mhm.
mean muscle weakness. First step is you are going to find out where is the
Pattern of.
localization for this pure motor syndrome.
Yes, sir.
Second, then you are going to think of whether you are dealing with an acquired syndrome or a genetic syndrome, whether it is
Mhm.
persistent weakness or fluctuating weakness.
Yes, sir.
Okay. Then goes to the pattern approach. So we'll
Pattern
go to the
approach.
pattern approach.
Yes, sir. Now we'll go. Pattern.
There are some positive symptoms, there are some negative symptoms.
Make it simple.
Yeah,
Yes,
that doesn't much value in the muscle disease actually. Value means, I mean, you tell whether it is positive or negative doesn't make so much sense in muscle for me at
yes, sir.
least.
Yes, sir.
Because in
That's
a
right.
peripheral nerve, it is very important to tell it is positive or negative. Because
Mm.
whether it is positive or negative, you divide it into two groups, that's all. But these are
Yes, sir.
symptoms like fatigue,
Yes, sir.
muscle cramps, or weakness, or sometimes myalgia, all those things.
ILGRs. Yes,
Okay.
sir. So, uh,
We
pattern
go to
of
the pattern.
muscle.
Yeah.
Yes, sir. The first is the proximal limb girdle weakness. It is the most common type of weakness in myopathies. This pattern of weakness is seen in almost every myopathy. So it is not very specific for any particular myopathy. So a distal weakness, which is Uh, Distal upper limb weakness is seen in the case of inclusion body myositis, where we have finger flexor weakness, in myotonic dystrophy, where we have finger extensors weakness, Parentis myopathy, the thumb and index finger extensor weakness, which is late onset, while
Yeah,
distal
just
lower limb post.
just go back to your patterns. Just go back to your patterns. First slide of
Yes,
patterns.
sir.
Yeah, yeah. Actually, the easy way to remember will be
Mhm.
first you study the proximal limb weakness. Okay,
Yes, sir.
proximal is a classical limb girdle pattern, which is common for any myopathies. Then
Mhm.
you go with proximal distal combined things. So that
Yes,
confusions
sir.
will be over because you can take
Mhm.
it as a proximal upper limb and distal lower limb
Distal
weakness.
lower limb, scapuloperoneal weakness.
They are facioscapular muscle dystrophy, scapuloperoneal muscle dystrophy.
Yes, sir.
Yeah. Then you keep the first slide only. You keep the first slide only.
Yes, sir.
Yeah. Then you remember first is a proximal limb girdle pattern weakness or proximal lower limb weakness or limb girdle pattern
Mhm.
weakness. Then you think of
Mhm.
proximal upper limb and distal lower limb. Then you come to uh, proximal lower limb and distal upper limb. In the
Distal upper limb.
proximal lower limb and distal upper limb, you have
Mhm.
myotonic dystrophy type 1
Not distal.
and
Mhm. Inclusion
you
body
have
myositis.
inclusion body myositis. Inclusion body myositis in the upper limb, it is more of the distal viscous
Distal
flexors,
weakness.
and lower limb, it is predominantly quadriceps.
Concepts. Yes, sir.
Yeah. So then it will be easy. Then you go to distal weakness because otherwise, in the distal weakness, only some of these entities will overlap. So
Yes,
you
sir.
will get confused. In order to avoid confusion, you go with proximal weakness followed by proximal upper
Proximal
limb.
arm.
Yeah. Then you go
Yes,
to
sir.
distal. Otherwise, you will get confused because these things with distal weakness will overlap there. So that to avoid that confusion, you just remember only the distal myopathies and distal weakness.
Yes, sir. We'll do that.
Yeah.
So this is a scapuloperoneal weakness. That is the proximal upper limb and the distal and lower limb weakness. Yeah, weakness in the periscapular muscles of the proximal arm and the anterior compartment muscles of the distal lower limbs. Scapular ringing is commonly seen in this. So the examples are scapuloperoneal dystrophies, EDMDs, LGMD1, 1B, 2A, LGMD, 2C, congenital myopathies, acid maltase deficiencies, FSHD, where we have a facial weakness as well. Then we have distal upper limb and proximal lower limb weakness, where pathognomic for the inclusion body myositis and myotonic dystrophy. Then we come to the distal myopathies, where distal upper limbs has inclusion body myositis, myotonic dystrophy, Wallender's myopathy, and in the lower limb, posterior calf weakness is seen in Miyoshi
Yeah. I
myopathy,
I'll
anterior.
tell you. I'll tell you an easy way to remember this.
Yes, sir.
Distal myopathy, you can divide it into autosomal dominant, autosomal recessive.
Yes, sir. Yes,
Yeah.
sir.
Autosomal recessive, you
Mm.
have Nonaka and Miyoshi.
Non-Miyoshi.
You remember Miyoshi, no shin weakness.
Mhm.
Miyoshi, no shin weakness. That is Miyoshi will
Mhm.
not have anterior compartment wasting, but it will have posterior compartment wasting.
Posterior.
Nonaka will have shin wasting. Shin is anterior.
And
Remembering that, you can remember like Miyoshi, no shin wasting.
mhm.
Then comes
Yes, sir.
the autosomal dominant one.
Mhm.
Autosomal dominant one, you can divide it into upper limb onset
Upper limb,
and lower
lower
limb
limb.
onset. In
Yes, sir.
upper limb onset, you have Velander. What I remember
Mhm.
about Velander is, what I remember using a mnemonic which I created is like a 40-year-old man fallen into the well, unable to climb up because of wrist weakness. It is predominantly present upper limb weakness. It's around 40 years, more common in men.
Mhm. Yes, sir.
Then that is upper limb weakness. Then comes the autosomal dominant with lower limb weakness. Autosomal dominant lower limb weakness can be divided into those less than 35 years and those more than 35 years.
Yes, sir.
Less than 35 years, you remember they are young. A young
Mhm.
is Liang myopathy. Liang and Yang
Yeah.
sound same. It
Yes,
is
sir.
Liang. It is young onset, lower limb dominant, autosomal dominant. So autosomal recessive, you have Nonaka, Miyoshi, Miyoshi, no shin wasting. Then
Mhm.
autosomal dominant, upper limb and lower limb. Upper limb, you remember Velander, a 40-year-old
Mhm.
male fallen to well, unable to climb up because of wrist weakness.
Mhm.
Then you have lower limb onset. Lower limb onset can be, I mean, lower limb type of autosomal dominant. that can be again divided into less than 35, more than 35. Less than 35, it is a young one. So remember
Young
Liang,
and
Liang. In that there is an N. That means they have neck flexor weakness and no rimmed vacuoles.
Yes, sir.
Distal myopathies will have rimmed vacuoles. This doesn't have rimmed vacuoles. Then lower limb onset more than 35 years. Lower limb onset more than 35 years. It can be one associated with predominant cardiac involvement. Predominant cardiac involvement is Marcus Berry Grieg. Again,
Yes, sir.
I remember is like Marcus Berry Grieg arrhythmia. That is one mnemonic I used to remember, Marcus Berry Grieg arrhythmia. Then you have remaining myopathies come in that is Williams and other myopathies.
Yes, sir.
That is one way to remember, because the questions will come randomly. It is very difficult to remember otherwise. This is the way I remembered it. Okay.
Myopathies with ptosis with ophthalmoplegia, where we have the OPMD, mitochondrial myopathies like CPEO, NMJ disorders, and ptosis without any ophthalmoplegia will be seen in myotonic dystrophy, is congenital myopathies, and Desmond myopathies, that is myofibrillary myopathies. Neck extensor weakness presents with a drop head. Prominent neck extensor weakness should be differentiated from anterior amyotrophic lateral sclerosis and myasthenia gravis as well, because they are the common causes of neck drop. And drop head in the myopathy will be seen in FSHD, myotonic dystrophy, inflammatory myopathy, acid maltase deficiency, and endocrine myopathies.
Also in isolated neck extension myopathy.
Neck extensor muscle weakness, yes, sir.
Isolated neck extension myopathy. There's a myopathy like that. Okay.
So dysphagia, prominent dysphagia seen in myotonic dystrophy, where the individual has monotonous speech, dysphagia, esophageal dilatation, in OPMD and inflammatory myopathy as well. Dysphagia should be differentiated with myasthenia, where they have chewing, swallowing difficulty, faciobulbar weakness. In ALS, there is spastic atropic tongue and fasciculations. So these are the total patterns of weakness as we saw. First is the proximal limb girdle weakness. Distal weakness, as Sir told, upper extremities, Wallander's IBM and myotonic dystrophy. Lower limb will be Miyoshi, Nonaka, Marcus Burgess and Woods. Scapuloperoneal weakness, FHSD, EDMD, ptosis ophthalmoplegia with myotonic dystrophy, OPMD, facial weakness, FHSDMD, and dysphagia and MD, OPMD. While leg muscle weakness and Pompey's FSHD, DMD, etc. So atrophy of the muscles. Atrophy in LGMD, there is a preferential atrophy of the hip adductors. Dysferlinopathy, the calf and hamstring atrophy is seen. FSHD has many signs like Popeye sign because of the wasting of a deltoid with trapezius hypertrophy. A myotonic dystrophy, they have hatchet face because of atrophy of temporalis masseter. The sternocleidomastoid atrophy will give a swan-like deformity.
What about
Atrophy is more
Carpon-Trophy
common.
sign?
Of what?
Carpon trophy sign, diamond on quadriceps sign.
Yes, diamond quadriceps is seen in this ferlinopathies, and calf hypertrophy will be
Not calf
sarcoglycanopathies.
hypertrophy. Carpon trophy sign. Carpon trophy. That is also, I think, I'm not remembering. I remember it as dysferlinopathy only, but you have to cross check it.
Yes, sir.
Carpon trophy and diamond on quadriceps.
Diamond sign is this ferlinopathy. So,
Yeah.
yes, sir. And atrophy will be more seen in the case of ALS. In myopathy, the weakness is more than atrophy. Hypertrophy, true hypertrophy is associated with myotonia congenita stiff person syndrome, while pseudo hypertrophy is seen in DMD, BMD, and LGMD. Hypertrophy is also seen in hypothyroid myopathy, amyloidosis, sarcoidosis, neoplasia, or an inflammatory or infiltrative muscle disease. Fatigue, exercise intolerance. It is very non-specific, less useful negative sign. It is associated with metabolic mitochondrial myopathies. So brief exercise in tolerance is seen in gluconeogenesis defect, while long exercise in tolerance is seen in a lipid metabolism disorders. Myalgia, it is
So how will
non-specific.
you pick it from your history, lipid or
Uh,
glycogen?
yes, sir. So in the case of glycogen, the sprint runners or running for
Yeah.
a short time will have
See,
fatigability.
some of the children, I had a
Mm,
patient. He was around 15, 16-year-old. He was otherwise fine. He went for a cycling for a long distance. After that, he had myoglobinuria. It has repeated
okay.
again. So
Mm,
such
long.
presentations are more common with fat associated because initial 5, 10 minutes or 20 minutes, it will be served by glucagon. After that, you request beta oxidation. That
Yes, sir.
requires fatty acid. So that is why fat disorders comes later.
Yes, sir.
And
So
more than fatigue, more important is post-exercise or exercise-associated cramps,
cramps, yes, sir. Right.
followed by myoglobinuria and
Mm,
rhabdomyolysis. That is classically seen in metabolic myopathies.
metabolic myopathies.
And anything else which like you very commonly see like patients go to gym and comes back with rhabdomyolysis. That is actually not metabolic myopathy. That is known as Couch-Potocco syndrome.
Mm,
Somebody who is inactive for a long time suddenly went to an aggressive activity or mountain climbing, you will end up with a myoglobinuria. That is not metabolic myopathy. That is known as couch potato syndrome.
couch potato syndrome, yes, sir.
Yeah.
Yes, so myalgias, they are also non-specific. Episodic myalgias are seen in metabolic myopathies, while constant myalgia is seen in inflammatory muscle disease. Myalgia are more likely because of orthopedic or any rheumatological issues. They can be seen muscle-related disorders like mitochondrial myopathies, inflammatory myopathies, infectious, drug-induced hypothyroid myopathy, even so cramps. Cramps are typically benign, occurring frequently in normal individuals and are seldom a feature of a primary myopathy. Cramps can occur with dehydration, hyponatremia, azotemia, mixed edema, disorders of nerve or motor neuron, as in amyotrophic lateral sclerosis. Cramp associated with the muscle diseases are seen in metabolic myopathies like McCarthy's or hypothyroid, the uh, glucose or lipid
Hello.
metabolism.
Yeah.
Hello.
How will you differentiate a cramp from contracture?
So the cramp is usually short lasting. It is painful. Contractures are long lasting. In on EMG, the contractures are silent, and
Yeah, that
contractures.
is also the point. EMG, it is be electrophysiology is silent.
Yes, sir.
Yeah.
Yeah. So contractures they are persistent and electrically silent. Early contractures are seen in EDMD collagenopathies like Bethlem's myopathy. Late contractures are features of DMD dermatomyositis. The contractures which are provoked by exercises are seen in glycolytic enzyme defects like McCarthy's or the phosphofructokinase deficiencies. Myotonias, it is a phenomenon of impaired relaxation of a muscle after a forceful voluntary contraction. They are most commonly involved the muscles of hand and the eyelids. Patients complain of muscle stiffness or tightness, resulting in difficulty in releasing their hand grip after a handshake, screwing the top of a bottle cap, or opening their eyelids if they are forcefully closed. Myotonia classically improved after repeated exercises. Clinically, myotonia can be demonstrated by percussion myotonia by tapping on the muscle, or action myotonia by voluntary contraction of muscles. Myopathy associated with myotonias are myotonic dystrophy, myotonia congenita, hyperkalemic periodic paralysis, and hypothyroid myopathy. Paramyotonia congenita, paradoxical myotonia. This typically worsens by exercises or repeated muscle contractions. Exposure to cold will worsen it. It is seen in paramyotonia congenita. Myoglobin urea is caused by rhabdomyolysis. Severe myoglobin urea can cause renal failure due to ATN. Exercise-induced weakness and myalgia. The individual will have exercise-induced weakness, myalgia, urine turns cola-colored or red during or after these episodes. Recurrent myoglobin urea are seen in metabolic myopathies. The causes of myoglobin urea are this in the it is a prolonged or intense exercises, a viral bacterial infections, drug toxins, NMS, heat strokes, inflammatory myopathies, sarcoglycanopathies, disorder of gluconeogenesis, lipid disorders, and malignant hyperthermia. The age of onset. The myopathies which begin at birth are congenital muscular dystrophies and congenital myopathies. In the childhood, we have DMD, BMD, FSHD, dermatomyositis, infectious or metabolic myopathies. Adult onset are polymyositis, FSHD, LGMD, endocrine or toxic myopathies. In elderly, inclusion body myositis and OPMD. So temporal evolution, we had seen this already. So if the weakness is constant, chronic, and non-progressive, it goes towards congenital myopathy. If the weakness is constant, chronic, and progressive, it is DMD, LGMD, myotonic dystrophy, or FSHD. If it is acute to subacute onset weakness, inflammatory myopathy, endocrine or toxic myopathies. Fluctuating weakness is seen in metabolic myopathies or periodic uh, paralysis. We should ask about the precipitating factors, like if there is an history of drug uh, w- which can cause a drug-induced myopathy. If the episodes are provoked by exercises like glucolytic pathway defect, episodes of weakness after a fever, CPT deficiency. Periodic paralysis is characterized by exercise or digestion of carbohydrate meal followed by a period of rest. Patient with paramyotonia congenital frequently report cold exposure may exacerbate their weakness. So, family history, X-links are Duchenne's, Baker's, and EDMD. Autosomal recessive, we have limb girdles, metabolic myopathies, Baker's myopathy, and maternal transmission is seen in the mitochondrial myopathies. Most of them are autosomal dominant, which are FSHD, LGMD, LGMD1, or OPMDs, myotonic dystrophy, periodic paralysis, paramyotonia, Thompson's and center core myopathy. Myopathy is associated with other neurological complaints like mitochondrial myopathies will have stroke-like episodes, headaches, myoclonus seizures. Low IQ is seen in DMD, myotonic dystrophy. Myopathies with peripheral neuropathy can be seen in alcohol abuse, chloroquine, amiodarone, pseudovidin,
See, one thing,
amyloidosis.
yeah, one thing just want to add you when you tell about my alcohol abuse. Alcohol-induced myopathy can have normal CPK. Keep in mind, like, you may see
Yes,
some cases. It may have a normal CPK, and then you have proximal weakness. You don't have any other cause, and sometimes in my MRI may pick it also. That is alcohol-induced myopathy.
yes,
And what about similarly in your dermatomyositis also sometimes you will get normal CPK. In such conditions, you should do actually an aldolase. Aldolase. But the aldolase also, I don't know about alcoholic myopathy. Alcoholic myopathy, it can be normal also. No, no. In other myopathies, CPK will be at least slightly raised.
slightly
Unlike
raised.
alcoholic myopathy. Unlike even if it is acute or chronic, it will be raised. Acute myopathies are usually inflammatory. That is why it is very high.
Very high. Yeah.
Yeah. But in alcoholic, it may be normal. I had few patients. Even they present within 4 to 6 weeks and all. The CPK, everything is normal.
Mhm. So, myopathy with a respiratory involvement, early and prominent respiratory involvement without cardiac involvement is seen in late onset Pompe's polymyositis, congenital myopathy like Nemalan myopathy, and LGMD 21. Early involvement of respiration with cardiac involvement is seen in myotonic dystrophy, myofibrillary myopathy, mitochondrial disorders like Kirin syndrome. Late onset respiratory involvement is seen in this dystrophinopathies, sarcoglycanopathies, calpainopathies, EDMD, and laminopathies. Cardiac involvement, cardiomyopathy is seen in Pompe's, LGMD, sarcoglycanopathies, DMD, and EDMD, while arrhythmias are common for EDMD, MD, uh, dystrophinopathies, polymyositis. Other systemic involvement like hepatomegaly can be seen in myopathy associated with deficiencies in acid maltase debranching enzyme and creatinine. Eye cataracts are commonly seen in myotonic dystrophy, where we have Christmas tree cataract and mitochondrial myopathy. Optic atrophy, pigmentary retinopathy are seen in mitochondrial myopathy. EDMD is associated with color blindness. Skin hair changes, myotonic dystrophy is frontal baldness. Rashes are commonly seen in dermatomyositis. Multiple lipomatosis is seen in mitochondrial myopathies. The mitochondrial myopathy is an FHSD has a sensorineural hearing loss. So investigation wise, the most important is the lab CK levels, NCS, EMG, genetics, and muscle biopsy. Creatinine kinase in most of the myopathies, it will be elevated. In the acute stage, it is often more than 100 times in DMD. It is markedly elevated in LGMD, 1C, 2A, and 2B as well. The level may not be elevated, may be normal in the case of corticosteroid administration, collagen disease, alcoholism, hyperthyroid, and profound muscle heaviness. That is the late stage of myopathy. So in the case EMG studies, EMG is mainly for the confirm the localization, can be a guide for muscle biopsy as well. It is to rule out neuropathy, NMJ, or any MND. So NCS are typically normal in the patients with just myopathy. Uh, Needle EMG will have a myopathic changes that is brief durations, a small amplitude, and early recruitment. A muscle
NCS also depends upon the weakness of the muscle.
weakness
NCS
of
can
the
be
muscle.
abnormal. Yeah,
Yeah, yes, sir.
NCS can shows pure motor, normal sensor,
So if
normal
it is an
snap.
early my myopathy, just myopathy, then
Yeah, depends upon
I
the
can.
weakness. If the, suppose a muscle is weak, CMAP will be weak.
Yes, sir.
The muscle you examine, and if suppose it is a distal myopathy, distal
Mhm.
myopathy, if you will be seeing a peroneal amplitude is reduced.
Yes, sir.
Yeah, so it depends upon the weakness, amount of weakness,
Mhm.
and the muscle you are going to examine. But snap will be complete normal.
Yes, sir. So biopsy, the muscle biopsy should be taken from the muscle with MRC grade 4 strength. Typical myopathic abnormalities like central nu nuclei, both small and large, hypertrophic round fibers, split fibers, degenerating and regenerating fibers. Chronic myopathies frequently show evidence of increased connective tissue and fat. Inflammatory myopathies, there is vascular inflammation between the endomysial and the perimysial connective tissue. So these are the various stains which can be used, like HNE stain for the general histology, the Gomorrah trichome stain for the mitochondrial disease.
We'll
The
go forward. These are not
will go,
required for
yeah, this
practical.
is
Yeah, we'll
yes,
just
sir.
see more theory
So
things.
yes, sir. So dermatomyositis. So we continue this, or
Yeah, just tell them
can
inflammatory myopathy only because that is important for your exam.
okay.
Yeah, in not yeah, dermatomyositis, polymyositis, and all these three things are that
And
is
IBM.
one important for your exam. Maybe they may ask what is a
Yes, sir.
histological because
Yes,
this is
sir.
commonly asked one.
Yes, sir. So
Okay.
dermatomyositis may have very fascicular atrophy, inflammatory cell invasion on the non-necrotic uh, fibers, deposition of complement is seen on the small blood vessels. In polymyositis, we can see there is variability in fiber size, scattered necrotic and degenerating fibers, endomysial inflammation with invasion of non-necrotic muscle fibers, and IBM, endomysial inflammation with invasion of non-necrotic muscle fibers, small group of atrophic fibers, eosinophilic cytoplasmic inclusions, and muscle fibers with one or more rimmed vacuoles lined with granular material. Rim vacuoles are seen in this. Amyloid deposition is evident on Congo red, TDP 43, and ubiquitin positivity. Mitochondrial typically will have the
This is enough.
red, red.
This will we don't need to discuss too much theoretical things.
Yes, yes,
So just understand that dermatomyositis, polymyositis, and necrotic myopathy. How to
yes, sir.
differentiate histology is one common questions during the Viva they may ask. So dermatomyositis, basically you should understand that dermatomyositis is condition where the inflammation or the disease is happening around the vessels, not in the muscle. So because it is like a vasculitis, somewhat like a vasculitis, where you have the vessel wall is inflamed. That is why inflammatory cells are seen there. So when vessel wall is inflamed, the vessel is located at the center, and the distal fascicles, which doesn't receive proper blood, will get atrophied. That is why it shows perivascular atrophy and
Yes, yes, sir.
inflammation within the vessel. While in polymyositis, it is inflammation of the muscle, where endomysium got inflammation. And
Mm,
because of that, you will see the non-necrotic muscle also shows inflammation because their inflammation is happening in endomysium, while dermatomyositis is predominantly affecting the vessel wall.
yes, sir. Yes,
That
sir.
is why
Very well.
pathological changes happens. And what about necrotic myopathy?
Uh,
Necrotic myopathy will have
necro,
necrosis with scanty inflammation.
sir.
The scanty inflammation. Inflammation is very scanty. That is one necrosis without much inflammation is a feature of necrotic myopathy.
Necrotic myopathy.
Yeah.
So molecular
Yes.
studies are also available.
Okay,
Other blood tests are this, which we can do
that's fine.
electrolytes. Yes, sir. But then MRI will show specific changes, which will be useful in selecting the. Yes, sir.
Nothing. Continue.
Yes, sir. Forearm exercise test for suspected metabolic myopathy. A threefold increase in the lactate level represents a normal response. A characteristic elevation of serum lactate after exercise is absent in PFK deficiency and myophosphoryl deficiency, and a reduced in phosphoglycerate mutation deficiency. Forearm testing is normal in all disorders of fat metabolism and also in some glycolytic diseases with fixed muscle weakness as acid maltase and deficiency. So these are the few pictures of a DMD where we have the calf
Ideally, lactate
hypertrophy.
ammonia both is what Bradley tells to check.
Yes, sir.
Somebody asked. Can read in the Bradley. I forgot the exact thing, but both are there.
So DMD we have hypertrophy of the calf and as you can see over here,
In
ligament
we
is
will
also
just
seen.
just go fast. This is just figures, no?
Okay.
Yeah,
Figure
fine.
FSHD, fish mother bear hatchet face.
Classical. Okay. So when I'll just summarize. Whenever you see a muscle disease, first thing, any muscle disease should be taken as a pure motor syndrome. Then you localize in different part of the neuroaxis. Then you see whether the weakness is episodic or fixed. Then if it is fixed weakness, whether it is acute, subacute, or chronic. If it is acute or subacute, think of acquired diseases first. If it is a chronic, think of genetic disease. That should be the first step. Then you're going to approach a muscle based on its 8 patterns. I'll tell 8 patterns. For easy remembering, you can remember the first 4 patterns are regarding limbs. Where you have first pattern is a proximal dominant weakness. Second pattern is a proximal upper limb, distal lower limb. Third is a proximal lower limb, distal upper limb. Then distal myopathy. These 4 constitute the classical 4 limb associated pattern. Then you can remember those associated with the craniobulbar and neck. That comes the next 4 things. Then first is a ptosis. Uh, Ptosis can be divided into ptosis, ophthalmoplegia with bulbar symptoms or with dysarthria. That is seen in OPMD. Ptosis and ophthalmoplegia. Then ptosis alone with some facial weakness. Then comes your bulbar symptoms. Then comes neck flexor weakness. Then I will give the 8th pattern as episodic weakness. Episodic weakness following exercise and without exercise. Following exercise with myoglobinuria can be couch potato syndrome, can be metabolic myopathy. Then episodic weakness without exposure to exercise is classically in periodic paralysis syndromes. So This 8 patterns are next localization. This will help you arrive at diagnosis. So at least if you are not able to remember the all the muscles in this each pattern, all these muscle dystrophies or diseases in this each pattern is almost impossible. You can remember the common things. So if you tell the proximal limb girdle, most of the myopathies, most of the metabolic, most of the toxic myopathies, most of the inflammatory myopathies, all inflammatory myopathies follows this pattern. Then distal weakness, then proximal arm and distal leg, that is a scapuloperoneal pattern. Just keep the initial slide. The pattern only. Okay. Then you have the distal arm, proximal leg. You remember two things at least: myotonic dystrophy type 1 and inclusion body masseter. Then ptosis with ophthalmoplegia and dysphagia, that is OPMD. Ptosis with ophthalmoplegia only is mitochondrial disease. Ptosis alone with some facial weakness, again myotonic dystrophy and facioscapular. Then prominent neck extensor weakness. Prominent neck extensor weakness can be non-myopathic cause also. ALS, GBS, neuromuscular junction. Then myopathic causes. Myopathic causes isolated neck extensor weakness, inclusion body masseter, and uh, inflammatory myopathies. Then bulbar symptoms. Bulbar symptoms are OPMDs are classically, and you can also see in some mitochondrial myopathies and sometimes also in the myotonic dystrophy spectrum. Then you have the episodic weakness. So this pattern should be something you should know. So these 3 steps is more than enough to diagnose practically. First is pure motor syndrome. Second is weakness, acute chronic. Third is his pattern approach. And remember distal myopathies, how to remember autosomal dominant, autosomal recessive and all. Okay. The second one phenomena is seen in McAllister's disease syndrome.
McAllister.
Yeah.
Glycogen.
Glycogen storage. I think the mechanism is actually after doing some exercise, if after a short break, they can again redo. That is what I think. Yeah.
Small breaks they take and they improve their stamina. That is that.
Yeah. That is because like they can get the glucose from the periphery. Like you will go with the next presentation.
Yes, I'll stop sharing.
Yeah. Good presentation. Thank you. The slides are very good. You include everything.
Hello, sir. Am I audible?
Yeah, audible.
May I start, sir? Yes. Hello, I'm Dr. Satish. I'll be presenting approach to element syndrome in context of roots, peripheral nerves, in anatomy, physiology, and pathophysiology. In first roots, dorsal and ventral rootlets come together to form roots, and which are further divided into anterior rami and second posterior rami. There are 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral.
Among this thing, only thing you should understand is this point. Practically, anterior rami and posterior rami, if there is a radicular involvement, if the root is involved, it should affect both rami. So what happens is on EMG, you will have paraspinal muscles also will show abnormal discharges. Spontaneous activity, physical manipulation will be there. But if it is a plexus involvement, where the anterior rami is only affected, you won't get anything from the paraspinal. So that is one point to differentiate between a plexus versus root, especially when you have a lumbosacral plexus and all, lower lumbosacral plexus and all. With EMG, that is one way you can differentiate, because anterior rami supplies only the dorsal aspect and sends to the basically the paraspinal muscles. Okay. We'll just discuss more practically for practical exam workers.
So, myotome group of muscles
And
supplied
that's
by.
fine. That's fine.
Yes,
You
sir.
can skip it because this is pure theory. Yeah.
Yeah. So myotome supplying the upper limb, C5 shoulder abduction, C6 elbow flexion and wrist extension, C7 elbow extension, C8 thumb extension and ulnar deviation, and T1 is finger abduction. L2 is hip flexion, L3 is knee extension, L4 ankle dorsiflexion, L5 big toe extension, S1 is ankle plantar flexion, and S2 is knee flexion. These are the segmental sensory innervation of upper limb. C8 is the medial most medial to the hand, and C6
I
is.
think this is from De Jong, right?
Yes, sir.
Yeah, there are some difference in this. If you see Harrison, Hutchison, De Jong, and other books, there are some differences about the C7 per se.
Yes.
C7, some textbook tells only the middle finger, but
Okay.
De Jong it is given like this. So that is because there will be some overlap will be there.
Okay, sir. So dermatomal regions most likely corresponding to a specific root, which without overlapping regions. So C5 include the deltoid regiment band region. C6 include the thumb and index finger, and C7 only the middle finger.
Yeah, this is what in this
Yes,
figure
sir.
you see the C7 is on the middle finger. That is a difference from De Jong. I also noticed this thing that De Jong only. De Jong has only De Jong shows this figure. Other textbooks, including the Hutchison, is different.
Yes. C8 is in the medial aspect of ring finger and little finger. T1 is the medial aspect of the arm and forearm. L1 is L1 and L2 are the pocket regions. L3 is around the knee. L4 is the medial calf region anteriorly. L5 is on the anterior and dorsal aspect of the leg and foot. S1 is on the plantar aspect as well as on the hallux, as well as on the calcaneal region. S2 is around posterior aspect of the knee. S3 is perianal region, and S4, S5 again.
Yeah, one thing I want to tell you is like you see the L5. That is one area practically you are going to need it because that is the same area, almost similar area supplied to peroneal nerve. So whether it is L5 or peroneal nerve differentiation is one is little toe and second is a medial side, near the medial malleolar area. In little toe is a little the skin of the little toe is again supplied to peroneal nerve only, but
Okay.
it is not L5.
Okay, sir.
And the medial part, that is a medial malleolar area, and the medial part is not, I mean, it is applied by L5, but it is not supplied entirely by the peroneal nerve. It is applied from the sural end.
Yes.
So that is practically one area where you can sensory picking up a foot drop.
Okay.
Okay.
So clinical
So
features.
we'll go in the approach to peripheral nerve. Approach to peripheral nerve can be dealt in two ways. One is anatomical, second is pathological. This is anatomical approach.
Yes,
You
sir.
divide it into root, plexus, nerve, and multiple nerves. So, how will you differentiate these three things?
So root will have dermatomal region pain.
Yeah, correct.
Yes.
Then,
And plexus will have more
no,
than one.
root has like dermatome, myotome,
And
reflex.
yes, sir. Root will
All
have.
these three will have particular root is affected, particular myotome is
Yes,
affected, particular reflex is affected.
yes, sir.
So suppose he has an L5 involvement, I mean C5 involvement, he will have weakness of deltoid.
Yes.
He will have decreased sensation over that area subject to C5. He will loss of C5 reflex, C5, C6 reflex only. Others will be spared.
Yes, sir.
That is a dermatomal, myotomal, and reflexogenic area supplied by the particular root only will be gone. And they will have root pain.
Yes, sir.
These are the 4 points tell you that it is root involvement. So root pain means it is a sharp lancinating pain. It is carried by which fiber? A delta.
A delta. Yes, sir.
Yeah. Okay. Then what about plexus?
In plexus, sir, more than one nerve is involved in one territory.
Yeah. One easy way to remember is whenever someone comes to you with a single limb involvement, sensory motor syndrome, and it is proximal plus distal.
Yes.
Always think of root, I mean plexus.
Yes.
If suppose somebody has a weakness of the shoulder and weakness of the hand, it's
Yes.
proximal plus distal, sensory plus motor, single limb.
Yes.
Think of plexus as first differential.
Yes.
So plexus are usually involving multiple radical, not obeying a single root, not obeying a single nerve, or one or two nerve territory. Multiple areas are involved. Usually proximal plus distal.
Yes. Proximal.
And when it is plexitis, not all plexus involved are plexitis. When it is plexitis, they will have pain also, severe pain also. And the pain is not like radicular. Pain will be more deep-seated, nagging pain. Then, so first is root, then is plexus, then is individual nerve involvement. You can pick up there only one nerve or another nerve supplied muscles, and those supplied reflexes will be lost. So then comes the isolated sensory. Then how will you pathologically classify neuropathies into? Demyelinating, axonal,
Yes.
and ganglional. So how will be demyelinating? How will be axonal? How will be ganglionopathies looks like?
Sir, demyelinating will.
There is nothing known as Valerian. Somebody commented Valerian is a degeneration process. That is not a pathological type of neuropathy. You have demyelinating, axonal, or a ganglional.
Sir, demyelinating pathologies will start with the motor sensory of the proximal and non-length dependent patterns.
Yeah. So you can remember, take a prototype. For demyelination, you take a prototype is a GBS.
Yes.
For axonal, you take a prototype is a diabetic neuropathy.
Yes.
So suppose it is a demyelinating neuropathy. Among the A, B, C fibers, which fibers are most myelinated? A fibers.
A fibers. Yes.
A fibers are myelinated, B fibers are thinly myelinated, C fibers are unmyelinated. So basically this demyelination affect predominantly those with myelin, that is A fibers will be dominantly affected. So A fibers carries basically posterior column plus motor. That is why GBS causes sensory is predominantly posterior column symptoms, numbness, paresthesias, rather than pain. Pain also can occur, but it is more common is this. Again, the pain in GBS is usually A delta involvement, predominantly A delta involvement.
Yes. Ataxia.
Then basically sensory, it is predominantly posterior column symptoms plus motor weakness. So demyelation will have involvement of predominantly myelinated fibers. So they will have weakness plus sensory, predominantly proximal, symmetrical.
Yes.
And they will be ascending. And treatment response are much better.
Yes.
While an axonal is classically axons, though among the ABC, which is a axon, without less myelin is C.
C fibers.
So axonal neuropathies affect predominantly C fibers. So C fibers carries pain. That is why diabetic neuropathies start with painful paresthesias. Any diabetic neuropathy patient has out of proportion weakness. Significant weakness in the beginning, it is not diabetic neuropathy, unless proven otherwise. You have to rule out other causes. So C fibers involved that produces the painful neuropathies. Again, length dependent pattern. What does that means?
Length dependent pattern is because of the dying back phenomena, sir. So if the pain paresthesias or weakness, it starts with the distal most part of the leg. So until they come.
Longest fibers will be affected.
Yes.
So longest fiber is a lower limb fibers.
Yes.
So it is why lower limb is first started, then goes to upper limb. When it reaches the knee, only upper limb is affected. That is a stroking and glove pattern. So glove one stroking is either cervical myelopathy or a CTS with neuropathy or something else. Atypical neuropathies. Glove one stroking is what is classical axonal pattern. I mean, stroking and glove. Stroking and glove is a classical axonal pattern. So they will have predominant pain, less weakness, distal dominant, symmetric.
Yes.
So that is a classical. And C fibers carries autonomic symptoms. So that is why it has autonomic symptoms also. So how does the autonomic symptoms happens in GBS? B fibers carries a preganglionic autonomic fibers. That is myelinated.
Okay.
That is affected in GBS.
Yes. Predominantly
So then,
proximal.
yeah. So Axonal is more distal, pain dominant, small fiber dominant, length dependent pattern. While demyelinating is predominantly proximal, symmetrical, sensory plus motor involvement. Sensory is predominantly posterior column sensation, and treatment response is much better for demyelinating. Axonal are usually all metabolic, vasculitic, all these are axonal.
Yes.
And compressive and other inflammatory neuropathies comes under demyelination. What about ganglional?
Ganglional, it presents predominantly with the deep-seated pain and as well as autonomic symptoms.
Ataxia.
Ataxia.
Significant ataxia is a classical feature of ganglionopathies. Ganglionopathies will show out of proportion ataxia. And classical ganglionopathies are, can you tell two ganglionopathies? Sjogren's and paraneoplastic.
Yes, sir.
So that is whenever you see a patient in any of these phenomena, keep it as axonal, keep it as demyelinating, keep it as ganglionopathies. And if somebody has a diabetic patient comes to this is something you should take always. Any patient diabetic comes to you with significant weakness, without much sensory, without much small fiber, early weakness. Always evaluate the patient. That is not diabetic neuropathy.
For demyelination.
It may be something else. It may be paraneoplastic. We don't know. Like you have to evaluate the cause.
Okay.
It's not a diabetic neuropathy.
Okay.
Okay. Okay, continue.
So neuropathy, sir. Neuropathy.
Yeah.
So neuropathy has predominantly two symptoms: negative symptoms and positive symptoms. Firstly, I'll discuss the type of fibers. So, Erlanger classification of peripheral nerve fibers. So group A fibers, group 1, group 2 and group 3. Group 1 is from annulospiral endings of muscle spindles, group 1A, and 1B are from Golgi tendon apparatus. Group 2 fibers are from flower spray endings of muscle spindles, and group 3 from pain and temperature receptors. So A and efferents are alpha, beta, and gamma. Group B and C are preganglionic and postganglionic fibers. So predominantly type 1A fiber is from muscle spindle, A alpha, 1B from Golgi tendon apparatus.
These things are actually not needed for a practical purpose. You just understand A beta, A B C,
Yes,
A alpha, A beta, A gamma. That is actually practically needed.
Yes, A is large while A delta is small, and C some fibers are myelinated and some are unmyelinated. A alpha and A beta are large and it conducts motor, and A delta conducts sensory.
A delta is also the large fiber only with
Okay.
myelinated, but compared to A alpha, it is less. That is only. It's not a small fiber.
Okay, sir.
That is also a large fiber. That is also has large, thickly myelinated. But among the A alpha, beta, gamma, delta is the last. Among them, most thinnest.
Okay, sir.
So you're discussing about, you put a slide on nodopathy. So it's just asking you when you suspect nodopathy.
Sir, clinically, if it presents like GBS, but predominantly very rapidly progressing, and as well as bulbar and cranial nerve
There are
involved.
two spectrum of nodopathies. One is acute presentation. Then second is chronic presentation. The acute presentation nodopathies are your AMAN, AMSAN and all,
Yes.
where you have nodal antibodies directed against GM1, GQ1B, GD1A, all those things.
Yes.
So other than that, there's a chronic entity. That is where you need all the evaluation. So in acute, when you suspect nodopathy,
Very rapid progression and non-responsiveness to IVIG, sir.
yeah, non-responsiveness IVIG is not always a feature because it depends upon which antibody you're dealing with.
Yes.
Suppose again, among the nodopathy, you have AMAN, AMSAN also is actually nodopathies.
Okay.
The reversible conduction failure, that is a classical feature of AMAN, AMSAN. And normal temporal dispersion with conduction block. So whenever you see a normal temporal dispersion with conduction block, you suspect it is the etiology is happening in the node, in acute nodopathies, acute presentations. And when the second is a chronic and subacute presentation where you discuss like it is not responding to IVIG or rapidly progressing. So that is an acute CADP presentation. So acute CADP presentation is another condition where you suspect a nodopathy. Then what about the chronic diseases, CADP like presentations? There are few points. One is distal dominant weakness. Second is significant ataxia with tremors. Then third is very high CSF protein.
Yes, sir.
Fourth is MRA showing root enhancement,
Yes.
thick root enhancement.
Yes.
These 4 conditions plus an acute CDP. These 5 conditions in a CDP, you should suspect nodopathies.
Yes.
Very rapidly progressing and distal dominant, significant ataxia, like that's like presentation. Ataxia dominant, tremor dominant. You think of possibility of a nodopathy.
Okay.
Because nodopathy is one hot topic. You may get some question from there if you have some peripheral neuropathy. So nodopathies, which are antibodies, you know?
So anti-contactin antibody neurofascin 155 and neurofascin 186.
So NF186 is nodal, paranodal, or juxtaparanodal?
186 is juxtaparanodal, sir. 186 is just.
186 is nodal, I think. 186 bar 140 is nodal antibody, which is associated with usually with the GBS-like presentations, acute CDP-like presentations. 155 is, you remember just few things. 155 is young onset, and usually in younger age group, 3rd decade or 4th decade, with again the same presentation, distal dominant, ataxia dominant and all. While CNT1, they present with nephropathy, because CNT1 antibody is again present in your kidney also. I mean, CNT1 protein is there. That is why they present with classically with nephropathy plus similar presentation, slightly older age, severe disease. Then Casper 1 present with painful neuropathy, severe unexplained pain.
Neuropathic.
And Casper 2 present with your Morrowind syndrome and all.
Hyperexcitability.
Yeah.
Yes.
Okay. So paranode is NF155, CNT1, Casper 1. I remember, like, I think it is like that. Node is 186. Okay. You continue.
I'll continue the approach, sir. Then.
Yeah.
Or should I read out the definitions?
Just tell what it will be for practical purpose. I will help you for exam.
So dysesthesia will be an unpleasant abnormal sensation, whether spontaneously evoked, which includes hyperalgesia or allodynia. Hyperalgesia is increased pain, pain from a stimulus that normally provokes pain, and allodynia is pain due to stimulus that does not normally provoke pain. Anesthesia dolorosa, pain in an area or region which is anesthetic. Causalgia is a syndrome of sustained burning pain, allodynia, hyperpathia after a nerve lesion, often combined with vasomotor and pseudomotor dysfunction. Hyperesthesia is increased sensitivity to stimulation, excluding the special senses. And hyperpathia is a painful syndrome characterized by abnormal painful reaction to a repetitive stimulus with an increased threshold. Hypoalgesia is diminished pain in response to a normally painful stimulus, while neuralgia is a pain in a distribution of a nerve or nerves. Paresthesia is an abnormal sensation, whether spontaneous or evoked. Distribution of weakness, we think about distal, proximal, or both, focal, symmetric, or asymmetric. Symmetrical distal and proximal weakness, we'll think about immune demyelinating polyneuropathies, acute and chronic, while asymmetric, acute or subacute sensory motor symptoms, we'll think of radiculopathies, compressive mononeuropathies, mononeuritis multiplex. Neuropathies by pattern, focal, entrapment because of myxedema, rheumatoid arthritis, amyloidosis, acromegaly, and compression, trauma, ischemic causes like diabetes and vasculitis, as well as leprosy, sarcoidosis, and neoplastic infiltration. On patterns of polyneuropathy, in mononeuritis multiplex, axonal pattern will be seen predominantly in vasculitis, diabetes mellitus, sarcoidosis, and Hansen's. Demyelinating pattern will be seen in the form of mononeuritis multiplex in the diseases of MMNCB, MADSAM, compressive neuropathy in multiple areas, and HNPP. Predominantly motor neuropathy will be seen in GBS, AMAN, CIDP, lead, porphyria, multifocal motor.
These questions are classical questions. Pure sensory, pure motor, predominant motor, then autonomic dominant. These questions will come in your exam, in your theory, in Viva exams, Viva pattern. So just remember all those things. At least few.
Yes. With facial involvement, bifacial involvement, GBS, sarcoid, HIV, Lyme's, CIDP. Predominantly upper limb involvement will be seen in MMNCB, MADSAM, lead neuropathy, hereditary motor neuropathy, and porphyria. With autonomic nerve involvement, we divide it into two, acute and chronic. Acute syndromes are GBS, GBS with pandysautonomia, porphyria, and toxin induced like vincristine. Chronically, diabetes, amyloidosis, and paraneoplastic sensory neuropathy, and HSAN, as well as HIV. Small fiber neuropathy examples are diabetes, HIV, celiac disease, Fabry's, Sjogren's, amyloidosis, HSAN, and Tangiers. Sensory ataxic neuropathies are Sjogren's, paraneoplastic, uh, and toxins like cisplatin and vitamin B6 excess, and CISP. Demyelinating, which causes sensory ataxic neuropathy, is Miller-Fisher variant of GBS, and IgM monoclonal gammopathy, tabes dorsalis, and chronic ataxic neuropathy with ophthalmoplegia, paraproteinemia, cold, and agglutinins, and anti-GD1 antibodies. Canomed. The temporal evolution of the nerve involvement, like we divided into 4 weeks, 4 to 8 weeks, and more than 8 weeks for acute, subacute, and chronic. Or from days to 4 weeks, we suspect EIDP and vasculitis, and for subacute, CIDP, and chronic, we suspect hereditary and diabetes. First, diabetes. Monophasic, progressive, or relapsing. Monophasic illness usually is GBS. Progressive is diabetes and CIDP, and relapsing is recurrent GBS. CIDP can also be relapsing. Same thing. Just a few more examples of acute onset. It comes under differentials of GBS also. Acute intermittent porphyria, diphtheritic neuropathy, thallium toxicity, or arsenic also. Subacute onset, like toxins, nutritional deficiencies, paraneoplastic syndromes, and CIDP. Chronic and insidious onset, hereditary motor sensory neuronopathies, dominantly inherited sensory neuronopathy, CIDP. Relapsing remitting will be GBS, CIDP, HIV, porphyria, and toxins. Hereditary neuropathy examples are CMT, HNPP, hereditary neuralgic amyotrophy, HSA, and hereditary sensory autonomic neuropathy, Fabry's disease, Refsum's disease, Tanger's disease, porphyria, and familial amyloid polyneuropathy. Does the patient have any other medical condition associated? We should take the history of diabetes mellitus, SLE. We should ask for rash, skin rash, and other system involvements, anemia. Preceding or concurrent infections, classical example is diarrhea in GBS. Gastric bypass surgery and nutritional neuropathies will present with ataxia. History of surgery, medications, any abnormal medications for toxic neuropathy, alcohol, dietary habits, and fixtures for zinc, leading to copper deficiency. Clues to diagnosis: viral illness and lifestyle, work and occupation exposure, alcohol abuse, vitamin deficiencies, and dietary habits will help us in diagnosing respective neuropathies, while over-the-counter drugs, vitamin B6 and zinc consumption, gastric bypass surgery, previous history of amyloidosis, thyroid, chronic kidney and liver disease. Should also take the history of malignancy and associated chemotherapeutic agents, connective tissue disorders, heavy metals, and detailed family history in the presence of for the presence of hammer toes, high arch foot, weak ankles, gait abnormalities for muscle dystrophies or CMTs for hereditary neuropathies, and possibility of tick bite in case of acute onset weakness. Drugs causing neuropathies are Classically, demyelinating neuropathies are caused by amiodarone, chloroquine, and gold, while axonal neuropathies are caused by vincristine, paclitaxel, colchicine, isoniazid, hydralazine, metronidazole, and chloroquine. Neuronopathy is caused by thalidomide, cisplatin, and pyridoxine. Sensory predominant neuropathy is caused by cisplatin and paclitaxel, while motor neuronopathy is predominantly caused by dapsone and lead. Sensory motor both by vincristine and vinblastine. Conditions associated with painful peripheral neuropathy: diabetes and prediabetes, alcoholic neuropathy, chemotherapy which is platinum based, paraproteinemias, vasculitis and connective tissue disorders, uh, heavy metals and other toxins, HIV, amyloidosis, and porphyria. On examination, we should always check for abnormal sensations, especially distal weakness, which distal and proximal both. It will have neuropathies will mostly have normal muscle tone and absent tendon reflexes, abnormal gait, and we have to always rule out evidence of upper motor neuron lesions. And for consideration of vitamin B12, copper deficiency, HIV, and adrenomyeloneuropathy for cord involvement. Early signs we should see for distal sensory loss to cold, pinprick, and vibration. Reduced early signs of neuropathies are distal sensory loss to cold, pinprick, reduced ankle reflex, rhombox sign, and impaired tandem walking, and toe extensor weakness. Where late features are distal loss of cold and pinprick, vibration and joint position sense, areflexia at ankles and knees both, foot drop, and inability to toe and heel walk. General examination, some clinical manifestations in vasculitis, you should look for purpura livido reticularis, arsenic and thallium intoxication, Mees lines, thallium poisoning for alopecia, cryoglobulinemia, purpura, leprosy will have skin hyperpigmentation, OMs will have skin hyperpigmentation, fibrous disease will have angiokeratomas, and giant axonal neuropathy will have curled hair. This is the livido picture of livido reticularis, and on the right side we have purpura. These are the images of angiokeratomas and skin pigmentation. You can see ichthyosis, we can see here Mees lines. For deformities and trophic changes, hereditary neuropathies will have Pescavus, hamartose in CMT, and overriding toes and ichthyosis in Refsum's disease. Chronic childhood polyneuropathies lead to deformities like talipus equinus, clawfoot, kyphoscoliosis. Anesthetic and immobile limb show tight and shiny skin, thickened subcutaneous tissue, curved nails, and diminished hair growth. Distal trophic ulcers and thinning of bones like neuropathic arthropathy in long-standing neuropathies. Cranial nerve involvement, external ophthalmoplegia will be seen in Miller-Fisher syndrome, trigeminal sensory loss in Sjogren's, lower cranial nerve palsy with gynecomastia in Kennedy syndrome, facial nerve, especially bifacial, in GBS, Lyme's, patchy in leprosy, sarcoidosis, and HIV.
Hello? Hello? Satish, I think you're not audible. Hello? Am I audible? Hello? Am I audible? Somebody asked, inverted reflex is radiculopathy or myelopathy. See, you must understand the concept of inverted reflexes. So, invert reflex means, suppose you have a lesion at C5. So, what happens is your C5, C6, so C5, C6 is a compression. What happens in the C5, C6, your element. At that level, you will have reflex loss. So, you will not have a biceps jerk. On supinator also, you will not have the flexion of the elbow. But what happens is the segment below that, that is C7, C8 and all, will have a human lesion because the human supply to C5C7 is gone. So that area reflex will be exaggerated. So when you hit on the supinator jerk, what you will get is instead of flexion of the elbow, and what you will get is finger flexion, that is CAT1 reflex, which is brisk. The CAT1 is exaggerated. The reflexogenic zone of CAT1 has gone up to the supinator level, and because of that, on hitting the supinator, you are getting CAT1. So that means that there should be an element at the level of the loss of reflex plus an human below. That can occur only in a myelopathy. And when you discuss about inverted reflex, actually there is two types of reflexes. One is invert, second is perverted reflex. Both are different. See, actually, this supinator jerk is a perverted reflex. While inverted biceps is a true inverted reflex because when you hit the biceps, you are supposed to get flexion. In an inverted biceps, what you are getting is extension. That is exact inverted action of the muscle. You are supposed to get flexion. Instead of that, you are getting extension. That is a true inverted reflex. But in perverted reflex, what happens is, like in supinator, when you hit over the supinator, you are supposed to get a flexion or brachioradial action. That is not happening. The inverted of that movement is an extension. That is also not happening. Instead, some other reflex is coming. That is why it is known as perverted reflex. You can refer to De Jong for this. Anything else? Sir, I think his internet got cut. So basically, when you are, I'll just summarize. Whenever you see a peripheral neuropathy, always try to look at in the both axes, anatomical as well as pathological. Anatomically, whether it is radical, plexus, or individual nerve or group of nerve or polyneuropathies. Then you can divide into motor, sensory, and all those things later. But if it is unilateral limb, proximal plus distal, sensory plus motor, always consider plexus. Then second step is you divide it into axonal, demyelinating, and neuronal because it will help you to find out the etiology of what is happening to the patient. Then only you see what is happening, then acute, subacute, chronic, depend upon that there is acute neuropathies, inflammatory neuropathies, or whatever it may be, you can approach. So rather than following a Pakka 1, 2, 3, 4, 5, 6, 7 step, I've just given the Harrison, I felt that is almost impossible. It is like mugging up things. So I feel this is a better approach for me. It worked. So you always look at neuropathy in that way and always think about the symptoms, whether it is positive, negative, sensory, motor, sensory, whether it is large fiber, small fiber. If it is large fiber, whether it is positive or negative. If it's small fiber, whether it is positive or negative. Then comes to the motor, whether it is proximal, distal, symmetrical, asymmetrical. Shall we wind off, sir? Hello? Did sir? Hello? Hello? I think anything extra you want to ask, you can even unmute and ask if you have any doubt. If I know, I will tell. Otherwise, we can read. About somebody asked about this one, no? Second one phenomena. Second one phenomena is basically same only. After giving a small break, they will get energy from the glucose. By like suppose you are done energy, I mean exercise, your muscle get increased blood flow is happening. Then glucose production from the liver also increases and increased glucose utilization. That is the reason why they will get second wind phenomena, as much as my knowledge. Not asymmetric attacks, it is symmetric attacks here, ganglionopathies.
एक मिनट एक मिनट
Audible? Hello.
Hello?
Am I audible, sir?
Yeah, audible. No audible.
Sir, sorry, sir.
What is this 4-near pattern? I am first time hearing of that. What is this? I don't know about it. Anyone has any idea about this pattern? 4-near pattern? I'll also check. I don't know. Satish?
Yes, sir.
Yeah, we are finished, no? I was just summing up when you were not there.
Okay, sir. My Wi-Fi was off, sir. Sorry.
Okay.
Yes, sir.
Hello, sir. Sir, can I ask you a question, sir?
Yes.
Sir, in polymyositis, how common is that myalgia, that pain is, sir?
Per se, polymyositis, myalgia are not that common. Um, uh, there was, I think, like when I was a student of Chandra Madam, at that time, Chandra Madam used to tell us, it is because of the inflammation of the perimysium is the reason for the pain. I don't know how much I remember and how much true it is. Madam used to tell that.
Within Bradley, it is mentioned that more is the pain, less the diagnosis of polymyositis.
Hello? It's not audible.
So therefore, I asked, always dermatomyositis have pains. This regarding this polymyositis.
Yeah.
Sir, am I audible, sir?
Yeah, now audible.
Within Bradley, it also, yes, sir. Because in Bradley, it also mentioned that more is the pain, less likely the diagnosis of this polymyositis. So therefore, I asked, sir.
Yeah, actually, whatever case I had seen, severe pain are there more common in necrotic myopathies.
Yes, sir.
From my experience, it's a very small experience. From my experience,
Okay, sir. Thank you, sir.
polymyositis is usually endomysial inflammation, and that is why one reason why the pain is not there, because perimysium is more sensitive to pain, is what I remember from Chandra Madam's classes.
Yes, sir.
Yeah. Anything else? Short latency, long latency test and all. Actually, I I studied during my DM. After that, I never used it. When you work in a private hospital, you cannot use these tests. So I forgot everything. That uh, it is there. I read from your NCS book only, but now right now I'm not remembering it. Because once you practice, only you will remember. Otherwise, you will forget. Shall we wind off? Okay, both the presentations were good. I think Shailesh sir is not there. So hope it helped you. And this element syndromes, you always should go in a pattern way to get into the diagnosis. Otherwise, melamine is the most difficult. In your practical practice, also, UMN is very easy. LMN, you don't have any evidence. Many of the LMN cases, you have to diagnose by using your own skills. There is, otherwise, you will be end up in investigating right, left and right. You will not get any findings. Okay, thank you.
Thank you, sir.
And both presentations were very good. And there was some network issues in the both presentations, but both the presentations very good and beautiful slides.
Thank you, sir.